Has any of you come across RPR test kit before? Hello? Please, can you hear me, please?
No, please. Yes, we can, please.
You are hearing me?
Yes, Grandpa, we can hear you.
Has any one of you come across RPR test kit before? Oh,
No, please.
Oh, okay.
I've seen it once, but we never used it.
Where? Because I'm aware that Confonachi microbiology uses it, and even the what do you call the blood bank also uses it, because in their screening they use both the strip and they also use RPR, and they use, as we move along, you see the reverse algorithm where they will initially use the strip, and once the strip is positive, they also go ahead and then do the RPR. Okay, all right. So this is a typical RPR. All right. So with in the box you have these things. There is RPR carbon. This is the test kit. The test card. So you are going to do the test on a card like this. Okay. Right. Of course, the cards are many, and as you see here, there's ones here. There are multiple cards, and this one example. And then once you finish, you have to. This is supposed to be disposable. You have to take it away. So let's see what is in the kit. You have the RPR carbon antigen reagent or the suspension. Okay, so this is the VDRL. This particular one here is the carbon antigen suspension. Okay, and then you have a positive control. This is the positive control. You also have a universal negative control. Normally, the universal negative control is usually saline. It's usually saline. All right, so, but this is the negative control. And then this is a dispensing bottle. This dispensing bottle, you see, this is the antigen suspension. Once you open it, you can deliver drops. And as we move along in the procedure, you will need 20 microliters of this for the test procedure. So what we do is that this is a suspension. You will mix it and put some into this container. So this becomes your dispensing bottle. And then once you uncover it, you place this needle. This needle is a blunt needle, meaning that the end here is not something like you can use it to take a blood sample. It's a blunt needle, and it has been made in such a way that once you put it on top, I hope you are following it. Once you put it on top of this one, then it means that you can dispense the antigen from here through this needle. Okay, so this becomes the dispensing needle, and like I said, once you open here, and then you now will put the needle on top of it. This is not the normal needle that we are using. This is a specially made needle, and it's blunt. It's blunt. It's not the one with bevel, which can be used to collect sample. No, blunt. And then it's been made in such a way that once the suspension is in here and the needle is on top of it, if you are dispensing it, the tip here will deliver 20 microliters. Okay, and that is very, very nice. So you have this as your suspension, and then once you mix and put some here, you don't have to put everything here. Otherwise, if there's contamination, you will spoil your whole reagent. So this is the actual reagent. You mix it. It's ready to make. So it's ready to use. Okay, it's ready to use. All you do is to mix it up, because it has carbon or charcoal in it. If you don't mix it, the charcoal will settle down, and then the top will just be some ordinary fluid. So you have to mix it. As you mix it, you can put any volume into this dispensing bottle. This dispensing bottle has this top, but this top must be uncovered. Once it's uncovered, the tip here, the tip of this one has been made in such a way that the needle end here can fit on top of it. If it fits on top of it, then it means that you can deliver or you can dispense. That's why I call dispensing needle, this one. You can dispense the suspension from this bottle, which is now a dispensing bottle, through the needle and then onto your test card. I hope it is you have followed it. Hello. Yes. All right. Yes. Okay. So those are the things. So we have the antigen suspension here. We have the positive control. You have the negative control. We have the RPR card test slice. So this is the card. They are normally a paper, special paper, of course, and then it is disposable. So at the end of the day, you have to dispose it, and then you can take a fresh one. All right, and then we have mixing sticks here. Because at the end of the day, you put the specimen here. Once the specimen is put here, you are going to make sure that the specimen is spread over the entire circle here. So you use a spreader like this one, okay? Then you use it to spread it. Now you can now bring in your suspension. Sorry, the antigen suspension. Mixing sticks. This is how they say so you use it to mix it, or the stirrer, okay, dispensing bottle on all those. So I think this is in brief, but of course, it depends on the manufacturer. So you may not see some with the same color. You can see some with different branding, but of course, it should be RPR, okay? It should be RPR. But basically, every RPR, irrespective of the manufacturer, will have these things that you're talking about. All right. So now let's look at the testing procedure. Now you know the kit, what is in it. Let's see the procedure. So we've also said that the RPR test can be performed using either serum or plasma. All right, so either serum or plasma, you can use the RPR. But with the VDR, it's strictly the serum and not plasma. And you explain why you can't use the plasma. And here too, you do not require heat inactivation. You can use serum or you can use plasma and do not require heat inactivation. And that's one of the reasons why people prefer it, okay? Of course, like all reagents, you bring reagents to room temperature before use. You label the test wells on the card with specimen identification. So over here, you see that here, the test card has been labeled to some extent. So 1, 2, 3, 4, 5, 6, and then up to 10. So if you have samples, all you do is to now say sample 1, you want to put it here, sample 2, you want to put it here, or you can decide that sample 1 will go for negative control, sample 2 will go for positive control, and then your number 3 here will now be your first sample. So this one, I think you can maneuver. You can decide to do it anyhow. If you have a test card which is not labeled with numbers, you can label it yourself. But of course, at any particular point in time, your positive and negative controls must be included in the batch of testing that you're going to do. Because as you know, there could be contamination that could cause false positive and false negative, and so forth and so on. So your positive and negative controls must be included in each batch. That, of course, if you test it for the day and it's working, for that matter, throughout the day, the number of cases that you want to test, you assume that your reagents are working. But if you did 2 cases today, and the next day you are doing another 1 case, you don't say that, oh, I've tested the positive and negative control already, because you never know. Out of a moment, your reagent can go off. So it is always important to include your positive and negative control. All right. So you label your test wells on the card with specimen identification. Dispense 1 drop of each sample. So, and here you're talking about 50 microliters. The normal pipette that we use, pasta pipette that we use in our labs, the normal pipettes we use in our lab is approximately 50, will deliver approximately 50 microliters. This one too, even though it's not exact, but mostly about 90% of the time, the disposable plastic pasta pipettes we use in our labs will deliver 50 microliters. So if you say dispense 1 drop, and then here you are talking about 50 microliters, it means that we expect that you are going to use the standard pasta pipettes. All right. So of each sample and controls, the positive and negative controls we're talking about, and then onto the separate wells, and the wells here are expected to give you a diameter of 18 millimeters. So this circles, the diameter is supposed to be about 18 millimeters, and that is supposed to be standard for almost all the RPR cards. All right. So, and then once you have it there, and then you are using a separate pipette or stirrer for each. This one is easy to understand. Then, of course, you spread the sample over the entire test circle using the flattened end of the stirrer pipette. So, like we said, you have dispensed 50 microliters, and what some people do to here, you see this stirrer here. This stirrer here, one end is a stirrer, and the other end can be used as your pipette. Have you seen some before? Has any of you seen this type of stirrer where one end is flat, we can use as a spreader, the other end is open like a pipette? Have you seen that type before?
Yes.
Okay.
Yes.
So if you don't have a separate pasta pipette, what you do is that once you take one of this, you hold it by the middle and squeeze it. Once you hold it by the middle and squeeze it, this end can be used as a pipette. So once you hold the middle and then put it in your sample, once you release it, this side will pick up the sample. Once it picks up the sample, you can deliver it here, and the 1 drop will also be equivalent to the dropper from the pasta pipette. So that's what I mean, if you get some, you can try it. It's very, very simple. All right. So you spread it over the entire circle, and then now you gently shake your RPR suspension. Now by this time your suspension will be in the dropper, okay, in the dispensing dropper, and not in the vial itself. So you dispense 1 drop, which is 20 microliters, and I've told you that this is now going to be your dropper. So this one is going to be put on top here, and this end will give you the 20 microliters. This one to this end will give you the 50 microliters. This one will give you the 20 microliters, and that is good to go. Now, do not mix the antigen with the sample at this stage. What it means is that initially, once you put on the sample, once you put a sample here, you will use the spreader to spread it all over. You use it to spread it all over. The next stage, once you put on the antigen through this dropper, don't mix it again. So initially, you mix you spread the sample over the entire circle. All right. So that's it. The next stage, once you mix your suspension or the antigen suspension and deliver a drop, just leave it. Don't mix it again. That's what you're talking about. So do not mix the antigen with the sample at this stage. Now, immediately place the test card on a mechanical rotator, if available. So in some labs, has any of you seen mechanical rotator before in your labs?
Mechanical rotator.
Rotator. Oh, I don't know, but mechanical rotator. Have you seen some before? Have you seen some before? You haven't seen mechanical rotator?
Is it the one that has been shaking?
It's like Once you put it on, then it will be shaking.
Yeah.
It will be shaking.
If you
don't have it, all you do is that. Okay, yeah, people call it the rocker. That's it. The same thing. Okay. So if you don't have it, then mechanically you yourself will have to be rocking it. Okay. You yourself have to rock it for about 5 to 8 minutes. And then now you examine for clamping. Okay. Remember, I'll keep on using the flocculation because the method, the actual method is based on flocculation and not agglutination. So if, let's say, you happen to be writing any external exams and then you are talking about VDR or this, and then if you don't take care, you'll be compelled to write agglutination. Agglutination is typically for antigen antibody. I explained that one yesterday. Flocculation is still antigen antibody. They also give you clamps, but the extent, the mechanism of the reaction is different. All right. So after the 8 minutes, you examine. You don't need anything. So you examine with the naked eye, macroscopically, for clumps. And the clumps here will be black because of the charcoal in it. All right. So this is very simple. Very simple. So if antibodies are present, the sample that you are working on, if the antibodies are present, flocculation show as black clumps on the white card. So you see that most of the time, the card here will be white so that the black clumps can come out visibly. Okay, it will be very, very visible. You don't need any assistance. That's why it's just naked eye examination. The intensity of the clamping can be slight clamping or intense clamping, can now indicate the level of reactivity. So once there's clamping, you say that it's reactive. So the reactive can be weak reactive, can be ordinary reactive, or can be strongly reactive, depending on the intensity of the clamping. Okay. All right. So, but non-reactive, which is negative, result is characterized by smooth, uniformly gray appearance. Of course, this one, there's an error here, of the test mixture. So you see that the test mixture, remember, you have a black, somehow black reagent, and your sample, which could be serum or plasma, has a yellowish appearance. So once it mixes with the black, it gives you a gray appearance. Okay, it gives you a gray appearance. So once you have seen that gray appearance, it tells you that no reaction has taken place, and therefore your result is negative or non-reactive. So reporting can be reported as strongly reactive. Like I said, say the reactivity will depend on the intensity of the or the concentrations of the antibodies that are present. So if it's strongly reactive, it means you have presence of large aggregates in the entire test circle. Right. If it's ordinary reactive, you also have large aggregates, especially in the center and of the periphery of the test circle. Weakly reactive, the presence of small or fine aggregates. And then non-reactive, smooth gray appearance with no aggregates visible. Okay, so that's the way to report. You can report non-reactive, you can report weakly reactive, reactive, and a strongly reactive. Okay, and whether it's weakly reactive or they are all positive, but of course it's like seeing malaria parasite and saying that 1+, 2+, or 3+. So the intensity will determine the number of pluses to give. So similarly, whether it is weakly reactive, or strongly reactive will be determined by the appearance of the clumps, how intense they are. And I hope it is something, even though you may not have done something before, anytime you get some, I'm sure with this briefing, you'll be able to do it without a problem. And so this is how it looks like. Okay, this is how it will look like. So here, this very smooth gray appearance, no clamps, and therefore it's non-reactive. This one, you see some clamps scattered around. All right, so it will be reactive. This one, you see the clamps here. The clamps here are more than the clamps here. So you can say that it's strongly reactive. Okay. If you have some occasional clamps around, then you can say weakly reactive. That is all. That is all. And it is something that any one of you should be able to do at any point in time. Okay. So if you do it now, I'm combining RPR and VDR. So now after a test, whether it's RPR or VDR, the interpretation will be the same. Okay, interpretation will be the same. So if you do the VDR or RPR and it is negative, what does it mean? It means that the patient doesn't have syphilis. Okay, but is that all? It could also mean that the patient has primary syphilis, but it's so early in the course of the disease that the test has not yet turned positive. I hope that we are following it. You see, in the primary phase, okay, it will take time for the antibodies to be developed. And so if you did a test and it is negative, it doesn't necessarily mean that the patient doesn't have syphilis. It could also mean that he has the primary phase of syphilis. And especially if you did the test in the early period of the primary syphilis, of course, it will turn negative. All right, so you should be able to scientifically explain what negative result with respect to RPR is or VDRL if it's negative. You just can't say, well, once it's negative, then it means that you don't have it. Yes, it means you don't have it, but it could also mean something else. It could also mean that the person has it, but it's too early in the day. Once we know that the primary syphilis to take some time, and you have taken the sample too early, of course, the patient should turn negative. Okay. Now, also, it could also mean that the patient had primary syphilis, had a positive test, and was effectively treated, and 6 months have passed. So we are giving you scenarios where you can have your test to be negative. If the time that you took the sample, if the patient was actually positive, and in the primary phase, you see, in the primary phase, you don't have too much damage done to the patient. And so if the patient is diagnosed early enough and then given effective treatment, and treatment is also very simple, except that we are not dealing with treatment as part of this program. All right. So all you have to do is to report that it's positive, goes to the clinician, the patient is given the appropriate treatment or management. Now, if the time that the diagnosis was made was within the primary phase, not much harm has done to the body system. And therefore, once the patient is treated effectively, within 6 months, the test can go negative. That's why we're saying that with the reversion, we are talking about 12 months, but it actually depends on the stage of the syphilis where the patient was given the treatment. So if the patient was given treatment in the primary phase, it can have total recovery and can have total reversion. And in that case, within 6 months, if you do the test again, the test will show negative. All right. So you are also giving a scenario where a negative report could also mean that, oh, the patient was positive because there was some clinical manifestations of primary syphilis. The patient was given treatment, and it's just within about 6 months and has turned negative. And that is also good to go. All right. So say when you have a negative report, what can it be? It could also mean that the patient has secondary syphilis, had a positive test result, and was effectively treated, and it's about a year or 1.5 years. So here you are giving you the impression that the patient can turn negative after treatment, depending on the stage within which the patient was treated. So you see that once the patient was treated within the primary phase and was effective, within 6 months, your report can go negative. If the patient was also treated in the secondary phase, then it is likely that we also turn negative within 12 to 18 months. That is after 1 year. Okay. Then what if the patient also has syphilis, but his or her immune system is impaired? In the case also, you can have a HIV co-infection with syphilis. if you have syphilis and you also have HIV, your immune system is compromised, and therefore your capacity to build antibodies is also compromised, and therefore it's likely that you have the syphilis all right, but because of your HIV status, syphilis is going to turn negative. So these are the things as scientists you should know, so that no doctor will come and bully you around. Oh, this is a clear case of blah blah blah, and then your test is saying negative. All right, so you should be able to arm yourself with some of this scientific knowledge to be able to not confront them, but to be able to engage the clinician in a manner that they also know that you also know you're on top of your game. All right. And then, of course, you also have false negatives. All right, which may occur when large amounts of antibodies are present. And we explained the proteasome phenomenon. He said that, especially in the latent phase, he said that in the primary phase, especially late primary phase, antibodies are now beginning to be produced. The secondary phase, you can get antibodies. In the latent phase, you are getting too many antibodies have been built, and that's where the patient looks asymptomatic, because he now have a lot of antibodies to protect. Meanwhile, the infection is still there. All right, so you have an overwhelming amount of what do you call it, of antibodies. And once there are too much antibodies, if you took serum from that patient, it's going to give you a negative report. Unless you are suspicious enough to say that, no, this is a known case of syphilis and he has not been treated. I don't know why he is still negative. I'm suspecting that there could be a proteasome effect. And then you do your dilution. Once you do your dilution, it will show positive. And once it shows positive, yeah, then you prove yourself that, wow, I thought as much. Okay. And for that case, you can say that the patient is likely to be in the latent phase, which is the third stage phase of the syphilis. And that, you know, once you're able to also stage it, when I say stage, meaning that you're able to determine that the patient is likely to be in the first stage. There is a primary or secondary stage or third. Each stage has its treatment regimen. Okay, so if it's going to be given one shot of benzapenicillin for primary phase, in the secondary phase, you'll be given 2 shots. If it's in the latent stage, you may be given 3 shots. You understand? So the stage of the syphilis will also determine the treatment regimen. So if you're a lab scientist and you're able to help the clinician to determine that, no, this case is a potential third stage syphilis, I'm thinking that the doctor will be very proud of you. Okay, all right. All right, so now you are able to explain. Yes, sir, yes, sir. Is somebody talking?
Yeah, so now yes, please. I want to find out. So in this case, how can we in our way determine the very stage that the patient is in?
Okay, very good. So we've seen that the clinical manifestation is also very, very important. For example, if he is in the primary stage, you will see the penile ulcers. That one, even if it has resolved. And remember, we said that sometimes within 3 weeks to 4 weeks or so, the penile ulcer, the chancre, will spontaneously resolve, will go away on its own. But the patient can tell you, though, I have some ulcer or I have some wound here or sore here, and now it's gone, even though I haven't taken any medication. You as a scientist will know that this is also natural. And you can tell the patient, yes, it's gone, but the infection is still there. The infection has now rather gone into the bloodstream. Okay. And then once you're, at that point, if your listening is negative, if your VDR is also negative, you can explain that, yes, it is in the early stage of the infection. And if, for instance, can you come in 2 weeks' time or in a week's time for us to repeat? So by 2 weeks' time, the patient comes, yes, the patient, this thing will have gone, but the test can now show positive. So in this case, it means that the patient is transitioning into the secondary stage. I hope that you get me. The patient will now have moved from the first stage to the secondary stage. So it means that if he's going to be managed by the clinician can also, the lab scientist can also help the patient sorry, can I help the clinician that yes, this is a positive case. I'm suspecting that it's likely to be a secondary disease. And by that time, the ulcer is gone. Once the ulcer is gone, this is positive. You know that last 2 weeks or so, he came here. There was the ulcer, but the test was negative, and you could now explain that at that point, the system or the body was now building up the antibodies. All right. And so you were not, even though the ulcer was there, you were not surprised that the test was negative. Okay. Now you ask the patient to come in 2 weeks' time. Once the patient comes in 2 weeks' time, by that time the ulcer is also gone. Yes, the test has now become positive. So it gives you the confidence that yeah, I thought as much. It was now either in the late stage of the primary phase or early stage of the secondary phase, in which way all these things, all this information should also guide the treatment of the patient. Like I said, the treatment of syphilis is very much dependent on the stage of the infection. And if you're in the lab, you can also use some of this knowledge to be able to help that, whether it's in the first stage or the second stage. And remember, in the second stage, there the patient is going to develop rashes. You can also, you see, one thing is that these days, doctors, they don't have time to examine patients. So that if the patient goes to tell the doctor, oh, I have some Krobi or Mebema, he wouldn't tell him, oh, if you're lucky, you can, so let me see the wound. But most of the time, as soon as he says, oh, I have some wound, the patient will say, I have Krobi or Mebema, straight away you think that it is syphilis, without even looking at the nature of the wound. Okay, but when it comes to the lab, probably you may be, if the doctor has written genital ulcer or something, you may be interested, you want to find out, you can just ask the patient, you want to have a look at the nature of the ulcer. So the nature of the ulcer too can give you a guide. Remember, I've said that the chancre is hard. It's also painless. It has a smooth line and so forth and so. All those things will guide you to know that it's syphilitic chancre. And I said that our next discussion may be on chancroid. And I said that the chancre and chancroid, as you all know by this time, the medical terminology with a suffix OID means like. So if you have chancre and chancroid, you're talking about chancre-like something. Okay. And that is typical of the hemophilus decree. And that one is soft. And that one is also very painful. So the doctor may not have a look at all those things, but for you as a scientist, in your own small way, you may want to have a look at these things and then give you a guide, because you may, the ulcer may be there, but if it is not a syphilitic ulcer, but rather chancre, and you did the VDR, it is still going to be negative. Then you'll be thinking that, oh, probably it is primary syphilis, and that is why it is negative. The patient goes to come in the next 2 days for you to repeat. The wound is still there because it is not syphilitic. It is rather chancroid. And then your VDR is still negative. Then you create a diagnostic problem for yourself. So once you have all this knowledge, you'll be able to put the, that's why we have what we call differential diagnosis. You know that it could be this, it could be this, it could be that. All right. So once it could be this or that and that, you try to rule them out by doing all the necessary basic tests for you to also come to a final conclusion. So ladies and gentlemen, I'm saying that yes, you don't have to just do the test and just report for the sake of it. You can also be interested in other information, and then that will now also help you to also help the clinician by suggesting that this could be stage 1 or stage 2 or stage 3 syphilis. Remember, we cannot do this at this time because almost all of us are doing the TP strip. And as we move along, it becomes very clear the TP strip is not non-treponemal, it is treponemal. And like we said over and over again, treponemal antibodies are permanent. And so once they are permanent, once they are positive, whether they have been treatment or no treatment, it means you can't use it in your staging. Stage 1, stage 2, stage 3, you can't use the treponemal. Okay. So that is where you have to get understanding of all these things, so that as you move along, you'll be interested in probably procuring RPR for your lab to be able to work out some of these things. Are you okay with me?
Yeah.
Yes, Grandpa. I think I get. So basically, we are to pay attention to the clinical
Clinical,
symptoms
very
as
important,
in
especially
doing
when
our
it comes
test.
to because sometimes, like I've said, most of the time the doctor, the clinician don't even have they don't take interest in examining the penile or SAR, the nature of it. They will just take that and then say go and do a VDRL. All right, okay, right.
Okay,
So
thank you.
now we have exhausted all the possibilities when it comes to non-reactive. When the test is negative, it is not just the fact that the syphilis is not there, but all other things that can give you a false, the negative. You have discussed them. What about when it is positive? So when it's positive to one, it means that the patient has the syphilis. Okay. Yeah. It could also be biological false positive, because you said that even malaria, even pregnancy, normal pregnancy can give you a false positive. Okay. So once it's positive, you don't just go ahead and say that, oh, the patient has syphilis. So you should be aware that a positive case, yes, could mean that the patient has syphilis. It could also mean that it doesn't have it. If it's a TB patient, don't be surprised that you do VDRS and it's positive. It has SLE. I'm sure you know SLE, systemic lupus erythematosus, one of the very common autoimmune disorders. All right. All those things can give you a false positive, and they call it biological false positives. So we also thought that the patient has syphilis, was effectively treated, but the test has not returned to a negative because it has been performed too early after treatment. You get a point. The patient has been treated. Now he came to your lab, you did a test, it is positive. It is confirmed that it is syphilis. The patients have been given the treatment. The next month he comes and you want to do the test. You think that it is going to be negative. They will still be positive. That doesn't mean that the treatment has failed. But you should know that, especially depending on the stage of the syphilis, it can take even up to 1 year for it to become negative. So if a doctor gives a patient treatment on syphilis and the following month he asks you to come and do the test, you should be able to tell the doctor that no, it might take not less than 6 months. If it is in the primary stage where you treated the patient, it will even take about 6 months for a test to become negative. So for you to ask the patient to come and do the test within 2 months or 3 months, the test could still be positive. And once it is positive, then that one, the more treatment. Anytime the test is positive, more treatment. Without taking cognizance or without getting the knowledge that the seroreversion, okay, will take time. Will take time. And so once you have all this information, you should be now also be in a position to be able to also help our doctors, also help our patients, because I think that patients are being overtreated for syphilis. All right. Now, once a positive test, what are the follow-up testing? So the recommended time period to retest patients who have syphilis and effectively treated as follows. So once the patient has been treated within the primary phase, your follow-up test to show whether the treatment has been effective or not should be at least 6 months. Anything below 6 months, when the patient comes, it's likely that the test will still be positive. You don't want a situation where you know that it may have to take 6 months for you to get the follow-up test, and then you do it earlier, and then it becomes positive, and then the patient is subjected to another round of treatment. Okay. Also, with a secondary syphilis, you take about 12 to 18 months for the test to turn negative. So if you want to do any follow-up tests, Okay, if you want to do any follow-up test to see whether the patient, then it should be about 12 to 18 months. All right. But remember, we've also said about the cellular reversion and then the fact that, yes, you may not necessarily wait for 8 to 10 negative, but you can also do the follow-up to check whether there has been a reduction in the titers. All right. And today we're going to go through the titer determination. So you may not necessarily have to wait for 12 months, but even after 6 months, which means that at the time that the patient was diagnosed, you should do your titer. And then that will become your baseline. And then that's where yesterday we talked about the endpoint titers. Okay, so that you know that, oh, at this time, the titer was, let's say, Y in 64. You are sure about that. Not Y, not less, not Y in less than Y in 40 or something. No, it was exactly Y in 64. So you put that information down. So after 6 months or so, 3 months or so, you can come and do the test. You know that to be positive, but you are going to depend on the rate of decline of the titer. So if it comes in and the next time after 3 months or even 6 months, and then it comes in and then you do the titer, the patient is positive, all right, and you know that was going to be positive. And then you do the titer, it has now come to 1 in 2. Straight away, you know that from 1 in 64 to 1 in 2, it's more than 4-fold declined. And therefore, you could be assured that the patient has had effective treatment. Okay, so these are the additional knowledge that we should bring to bear in our practice. And that is where the clinicians will also know that, yeah, you are not doing the test for being sick, but you know exactly what it is and their clinical interpretations and their so forth and so on. All right. Okay. So the longer syphilis remains untreated, the longer it will take for the test to return to normal. I hope that point is also clear. So if the patient it has taken too long for the patient to be treated for syphilis, then it will also necessarily take too long for cellular reversion to also take place. Remember, cellular reversion is talking about where the test will no longer be positive. That may be a long, long time. If you don't want to wait for that long time, you can also do the titer variation and see whether the treatment has been effective. Now, so that is enough about the non-treponemals, okay? So just a little about the treponemals. So treponemal tests detect antibodies specifically targeting the T pallidum. We've said this already, and are used for confirmation. This we know already. And then we say that all initial reactive non-treponemal tests should be reflex. I've just bolded the reflex because I want you to understand the word reflex means go to and go back and do something. Okay, so for example, if you want to do HB electrophoresis, you may have to do your cycling first. And then if it's positive, you reflex, you go back and do your electrophoresis. It's not like you do it for everybody. But for example, if you even do urine RE, you may do the reflex. Some doctors, so I just want you to understand the concept of reflex. Hello? Is somebody asking a question? Okay, I just want you to appreciate the concept of reflex testing. Reflex testing is you do a certain test and you go back and do another one. So if you do urine RE, for example, and then it's showing a lot of passes, and straight away you go back, you may have to go back and then do the urine culture straight away without waiting for her. That's what we call the reflexing. All right. Here, doctors are not, but you are not being trained for just Ghana. You are being trained to be a global lab scientist. You may find yourself elsewhere where they use the concept of reflex testing. That's why I've added this one. So reflexing means that once you do this and it is that, go ahead and do something else. This is what the reflexing is all about. So all initial reactive non-treponemal tests should be reflexed. What it means is that if you do the test for non-treponemal and it is positive, go back and do the confirmatory test. That's all we're talking about. So confirmatory testing is not performed if syphilis screening is not reactive. This one is important. If you did the non-treponema and it is negative, you don't need to do the treponema once. You don't need it. It's just a waste of time. So now let's look at some common assays for testing syphilis, the treponema ones. For the non-treponema, we know there are just the two, the RPR and VDR, and we talked a lot about them. Okay, right. For the treponema, there are a lot of them, hosts of them. I just mentioned some of them so that once you come across, if you come across a test and they say that it's based on, let's say, frozen treponema antibody absorbent, you know that it is treponema. Okay, right. So we are mentioning some of the common treponema tests, so that if you happen to get any test and they say this test is based on this assay, then you know that you are dealing with treponema. So you have the frozen treponema antibody absorption test, which is the FTA-ABS. The ABS here is the absorption. Okay. Then treponema pallidum heme agglutination assay. This is the very popular one. All the doctors know. Just as the doctors know about VDRL, they also doctors know about VDRL. They don't know about RPR. Take note. All the doctors will write about VDRL. They don't even know that VDRL is no more in the system. They will keep on writing VDRL. All right. So if they write VDRL and then in your lab, you are having the RPR, you do the RPR and report as VDRL stroke RPR. You don't have to, you see, because if you don't show that, yes, you did the VDRL, and VDRL is the same thing as RPR, it means that you are not being truthful. The doctor requested for VDRL, you did RPR, and then you are reporting the RPR as VDRL. That is unprofessional. But what you can do is that you write VDRL stroke RPR to mean that VDRL and RPR are interchangeable, or you can use them the same. So you can write VDRL RPR, then you write your report. But it is wrong to be using the strip which is based on treponema pallidum and then be reporting that as VDRL. Very, very wrong. Even though that's what all of us are doing in our various labs. You use the strip and then report it as VDRL. Okay. I hope I'm speaking to somebody. So the TPHA, the doctors know about TPHA. They are taught in school. So they know that if you do the VDRL is positive, do the TPHA. So most time the doctors will write the VDRL. They ask the patient to come to the lab. The lab will use the TP strip to do the so-called VDRL. And then once the report go back to the doctors know that when your VDRL is positive, you have to reflex, you have to go back and do TPHA. So the same patient will not come back to the lab with TPHA. Then the same lab will use the same strip and do the TPHA for the patient and to become positive. And then, the doctor says, so VDRL was positive, TPHA is also positive. Then this is a true case of syphilis. Then they jab the patient. It could be your sister. It could be it can even be you yourself. Okay. So all these tests, the frozen treponema pallidum heme agglutination assay, which is the TPHA, macro heme agglutination assay, treponema pallidum particle agglutination, TPPA, treponema pallidum immobilization test. These are all typical examples of treponema assays. The enzyme link immunosorbent assay, which is also very popular to ask the ELISAs. You have the enzyme link immunosorbent assay, which is, sorry, this is a repeat, sorry. The enzyme link immunoassay with ELISA, which you know. Then the enzyme immunoassay, EIA. This one is ELISA, this one is EIA. And a very popular one on the market is omega pathozyme. That's why I use that one. And then you also have immunochromatographic treponema assays. This is what is in most of the systems with the strip. Most of the, about 90% of them are based on the immunochromatographic treponema assays. All right. Some are using the enzyme immunoassays. Some are using the chemiluminescence. The biochemists, I'm sure you know this, immunoassays, the CIAs. These are all typical typonoma assays. All right. And these are all classical examples. Here we don't have them. I don't think we don't have them in our routine labs. Okay, but it's important to know about them so that you will never know if you find yourself in some advanced facility that may have them. Then you know how to also deal with them. So they are all typical typonoma tests. Now let's go to the POC, the point of care. The point of care is the strips that we are using. And you know that the POC, the point of care, were actually not designed for the lab. Any test which is rapid, like the RDTs for malaria, they were supposed to be non-laboratory based. They're supposed to be using outside the lab. But unfortunately, these days, almost all the RDTs are also being used in the labs. However, the RDTs were supposed to be point of care. That's the best side. It means it can be used by the nurses, can be used by the clinicians, can be used in the clinics. And once those things are available at the bedside, that's where they have to use it. And then once they come to the lab is supposed to do the classical laboratory-based testing to confirm the point of care. But unfortunately, the doctors may use RDTs for malaria in the clinic. When they ask that go and do the malaria test in the lab too will also use the RDTs. Did we go or did we come? All right. So the POC, which is the point of care serologic testing for syphilis, we are talking about the rapid test kits for syphilis, which are currently available in the market. And they can be considered as treponema non-laboratory based POC. What it means is that they were supposed to be developed for outside the lab use, non-laboratory based. They are non-laboratory based point of care serological tests. Okay. Now, and here we are saying that they are treponema non-laboratory based. What it means is that, yes, they are not supposed to be used in the lab, but technically they are laboratory, they are treponema based tests. And it means that they are specific. And because, why are we saying that they are treponema? Because the format, the way they have been produced, are developed based on immunoassays. And remember all immunochromatographic principles. And remember we said that the immunochromatographics and then the chemiluminescence, they are all, and then the enzyme immunoassays, they are all treponema. So if you develop any format based on any of these ones, then know that you are dealing with treponema assays. This is very, very important. So the point of care strips, the TP strips that we are using are all treponema testing because they are based on either enzyme immunoassays or immunochromatographic. And these principles are developed to produce the test strips. I hope somebody is hearing me.
Yes.
All right. So,
hello. Okay, so I want to ask a question here. Is someone talking?
Sensitive and they are specific. And because of that, they are yes. please.
Maybe some settings at my end. Because once I'm seeing you, it means you don't have a problem. I do.
Apartments.
Lisa.
I'm waiting.
Very sorry. Another challenge. I went off. Thank God I'm back. So let's see where we were. Hello, please. I'm back. Somebody was asking a question before I went. That we are learning tonight is that the rapid case for based on and all of us know that treponema also not be used to monitor stage. All this while we've known that I don't know why this is happening to me. Please, can you see my slide again?
Yes.
Okay. All right. Okay, so we'll go off soon. All right, so we can use the rapid TP test case for screening, because you know that for screening you will need to be using the non-treponema. All right, so once the TP is rather specific, then it means that they are not suitable for screening. Again, the test case can remain positive even after successful treatment. This one we have come to know that, and for that matter, they cannot be used to monitor treatment response. Okay, and they're also not useful in detecting reinfection. These are all things that we have to know, so that even as we are using the strip, we should know the limitations. Then we are coming to the algorithms. I think we have virtually have a good understanding of the algorithms.
Hello, Grandpa.
Syphilis, yes, sir.
Yeah, I was about asking a question and the network issue came. I don't know if my question has been answered throughout the past 5 minutes, but I would like.
I went off myself, so please come again.
Okay, so the question I wanted to ask is, so now I have understood that the VDRL are non-treponema tests, and then when we were dealing with the techniques in the treponema test, we mentioned immunochromatography as one of the techniques that the treponema test that we use. But the question I have, now I see some of the RDTs in the market or in our lab that they are written VDRL, they are RDTs. And know the RDTs are serologics and the immunochromatography. So those RDT that they are written VDRL, are they for non-treponema or they are treponema?
Okay.
Only on the RDT issue.
What I can advise you is to try to always, because I don't want to bring anybody's business down. So what you can do is always try to read the insert, what it is, what are they actually testing? Okay, if they say that is a strip, yet it has been developed based on RPR, so be it. If it's a strip,
yeah,
based on
I read one of the leaflets, I think yesterday, the one with the VDRL, especially the one that they have done in combo with the HIV testing. That one they were saying is non-treponema, and the syphilis TP is treponema. So the techniques we are doing now and how they have developed is getting me confused.
Okay, so like normally once a new system comes in, we don't interrogate them. Sometimes in elsewhere, they will try to test it alongside establish if it is the combo one. I haven't seen the combo type, but I'm sure some of you may have seen something. I don't want to dispute it. But elsewhere, they'll try to run the combo alongside the established, let's say TPHA or something, and then they try to validate it and say that this is good. It runs of the same, I mean, they have the same specificity and sensitivity as the traditional ones. Then you can go ahead. But these days, people don't do test validation. All they know is that, oh, the test has come. And then we don't interrogate it, we don't do anything, then we begin to use it. So 2 ways, either somebody can take it as a project. If somebody is doing some postgraduate work or something, you can use one of these new kits that's coming up and validate it against the established standard or gold, we have gold standards. Okay, you have the gold standard determination for non-treponema, which is the RPR. You can use the strip one, the combo one, and then run it alongside, and then you can publish. All right. Or you can use the combo one, the one they say is based on TP, and then run it alongside TPHA or any of the ELISAs or something. And then you establish, because the ELISAs are gold standards for the treponemas. So I don't want to say that whatever is on the market is not good, because I haven't done any tests on them. But some of you can use it as a project. If students are coming to your lab or something, or you yourself, you're doing a master's program, also you can do that as validation. All right. So that is what I don't want to say don't use it or use it, but you can read the manufacturer's insert, and then you can also interrogate the principles. If the principles is in tune with what you know, then of course, otherwise I will, like I said, I advise that you can do test validation by comparing with the established gold standards. Is that okay? Hello? All right, so let's move on. So like you said already, we have 2 algorithms. And our algorithm is that the sequence in which of performance of tests, that's an algorithm. So we have 2 pathways or 2 algorithms, the traditional algorithm and then the reverse algorithm. And then the traditional one, as all we know, you do the non-treponema test first. And if the non-treponema test is positive, you go ahead and then do the confirmation with the treponema. That's the normal algorithm. And so you call it traditional. So traditionally, that's the way to go. You always will do a screening or the non-treponema test, which is either RPR or VDRL. And you have also said over and over again that RPR is now very dominant. VDRL, people, because it is cumbersome and it is also time wasting and so forth and so on, people are no longer using it. But RPR is in the, I know RPR is in the system, and it's also as good as the VDRL. Okay, so if you have it, then you do that one first, and then you do the treponema, which is the confirmatory as the specific one as the confirmation. So that's the traditional algorithm. This one, there's no dispute about it. So in the traditional algorithm, the step 1 is that the non-treponema test is used as first-line screening. And then your step 2 is treponema test for confirmation if the screening test is positive. That's all. And this sequence has been widely used for decades because non-treponema tests were relatively inexpensive and treponema tests were also manual. So people felt that it's always easier to go by the traditional algorithm. Now, just as we talked about the RPR taking over from the VDRL, you also see that now the traditional algorithm is also now going away. It's now also going away, and then it's now going by the reverse. So by the traditional algorithm, an treponema test is done first as a screening, followed by a treponema. So that's the normal algorithm. However, screening for syphilis with specific treponema tests is also a practical option. What it means is that it's also not a bad practice to also use the specific treponema test first. Okay, so a treponema test can now be used as the initial screening test, and reflex. And here, I'm sure by the way I'm using reflex, you are getting very used to the reflex testing concept. And reflex or go back to the non-treponema test if the initial treponema test is positive. This testing strategy is what is called the reverse sequence algorithm, or for short, reverse algorithm. I hope the point is clear. That it is not bad to start with the treponema test first, or for that matter, the strip test. It is not bad to do that one. So don't say that, oh, now they say that we should have done the screening first with the non-treponema and do the confirmation. Now, the reverse algorithm concept is telling us that it is also good to start with the treponema, which is the specific one first. And once that one is also positive, you can go back. And so that becomes the reverse algorithm. So in the reverse algorithm, a treponema test, which could also be the RT. The RT is the rapid test, okay, or EIA, TPHA. The EIA and TPHA, now it's also difficult for us to do in our labs, but the RT is very, very common. So the rapid test, which is also a treponema test, can be used as the initial screening test. And when, if it's positive or reactive, you must now be followed by an treponema test. And this is all about the reverse algorithm. So in the reverse algorithm, the step one, use the treponema test as your first line screening. Step two, use the non-treponema test for confirmation. So it is the reverse of the traditional algorithm. And now I think this is what people are doing. So if you take a look at this, the traditional one, you do the VDRL and for that matter, RPR. And then if it's reactive, you do the TPHA. Okay, if TPHA is positive, then you have diagnosed your syphilis. If you do a VDRL, it's reactive. You do your TPHA, it is non-reactive. Then it is biological false positive. Because this gave you, this one was reactive. So it means that this gave you a positive report. Now, if you did your treponema, which is specific, it became negative. Then it means that this biological false positive. All right. If you do your VDRL, or for that matter, RPR, if it's non-reactive, you end there, no syphilis. You come to a reverse, you have your TPHA. Now you can't do your TPHA, you do just your normal strep test, which is also treponema. You did it. If it is positive, then you go back and do your VDRL. So if you do your VDRL, it is positive, yes, you diagnose your syphilis. If you do your VDRL, it is negative, you can do, sometimes you can do another, this FTA apps, you know, the frozen treponema antibody absorption that we talk. It's also a type of treponema test. So what it means is that it's like you want to double check. So you did your first treponema one, and it was positive. Sorry, if it's positive, you do your VDRL and it is positive, you are there. But if it's negative, you want to do a second, it's like you are doing a treponema test using using another method. Okay. And if you use another method is positive, then it means that syphilis is there. Okay. If it is negative, you know, sometimes you call some of this one the tiebreaker. The tiebreaker. Have you heard about tiebreakers before? Hello? Have you heard about a tiebreaker before?
No, please.
No, please.
Okay. So you do one test. This test, you are using a method A. The method A says that it is positive. Then you use method B. Method B says that it's negative. You can't say that because you use method B and then method B says negative. It means that the B one is correct. Because you use two different methods. One says it is positive, one says negative. So you need another third method to break the tie, because this one says positive, this one says negative. You can't say that the result is positive or negative. So use another method. If the third method that you use also say positive, then you confirm the first positive that you it's like this one is breaking the tie. You call it tie breakers. So you have one method. One method says that it's positive. Another method says that it's negative. So will you say that the answer is negative because the second one said it is negative? Are you going to take the second one? What about the first one which says positive? You can't say it. So you need a third one. When the third one says negative, then you can say, okay, two of them are saying negative. So it means the result is negative. If the third one says that it's positive, then the two of them are saying that it's positive. Therefore, the result is positive. That's why the third test that you do is going to break the tie. So we call it a tiebreaker. So you know that this FTABS is also a treponema test. Okay, this is a treponema test. The first one you did is also a treponema test. So if you did the treponema test and then it's also positive, then it is confirming the first one. But if you did a treponema test, it says a negative. Then it means that it is also because this one first and foremost said is negative. So the third one that you said is also negative. Then you also rules out the syphilis. So unfortunately, in our part of the world, we don't have the benefit of FTABs, TPHs, and the ELISAs, and so forth and so on. Okay, all we have is the strip. And then we don't even have the, what do you call it? We don't even have the the RPRs. So as you have all this information, you can now begin to see what you can do best in your various laboratories to improve on your serodiagnosis of syphilis. All right. There's another route. Here is the same thing, the traditional one, the non-traditional one. All right. So the question is, which algorithm to use for the syphilis? Which algorithm? You talk about the traditional and then, so which one will you prefer? So the two algorithms which are currently used, they are all recognized. They are all good. Okay, the traditional algorithm uses, as we know already, blah, 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 and then the non-traditional. So this is just describing. So both traditional syphilis screening algorithm and then the reverse algorithm are acceptable. They are both acceptable. The one to choose to use will depend on one, your laboratory resources. The choice of a specific testing strategy or preferred algorithm should be based on laboratory resources, your resources, including your staff, your workflow, your space, the cost of the test volume, patient population, service, and so forth and so on. So you take a lot of things into consideration and then decide which one to go. But most laboratories are now going by because non-treponema tests are mostly manual assays. Most high volume laboratories have chosen to adopt the reverse algorithm. Most labs are using the reverse. Nonetheless, the determination of which one to use is ultimately institutional dependent. So it means that now you have A or B, they say they are all good, and then which one to use will still be institutional based. So you can decide based on your availability of your resources and say that you want to go by the reverse algorithm. You want to go by the traditional algorithm. So that's that. Okay. So how syphilis is used? Syphilis strategy, how is it used? One, for screening, we all know, especially for pregnant women. Okay. Why do we use for pregnant women? We know that syphilis can be transmitted from mother to child, which we know as the vertical transmission. Do you remember vertical transmission? Where from mother to child is from one generation to another. And so it's from up to down. And anything moving up to down is vertical and a transmission. So once we have a mother to child transmission, it is also called vertical transmission. And it is not all diseases that can be transmitted vertically. All right. It is not all diseases. But for syphilis, it can be transmitted through the placental transmission. And therefore, it is important to screen pregnant women. Okay. It's also for diagnosis. There's syphilis source for diagnosis. And that one, you need a combination of the treponema and non-treponema test for your diagnosis. Okay. It is also for treatment monitoring. And this one here, the non-treponema test becomes very useful. You can use the treponema test to monitor treatment because we said that after treponema treatment, for as long as the patient has been exposed to syphilis and it develops antibodies, the antibodies will be there for life. They are permanent. And therefore, you can use treponema test to monitor treatment. However, because the non-treponema test can also vanish or can go away or can decline or decrease with respect to treatment, then it means that you can always be using the non-treponema test to check for or to monitor your treatment. It can also be used for detecting reinfection. All right, so that once the patient was positive, they has been treated and goes away, become negative, and another time you are testing again, become positive, means there's reinfection. And that one too, you can only use that one for the non-treponema. All right. Then also diagnosis of neurosyphilis. Okay, so you also need it for neurosyphilis diagnosis. All right. So still on the interpretations. So if your treponema test is positive and non-treponema test, so if it is positive for both treponema and non-treponema, what it means is that the patient strongly suggestive of active or past infection of syphilis. Positive treponema, negative non-treponema may indicate a past infection. I hope this point is also clear. If you do a positive, just as we are talking about the reverse Andrology, if you use the strip and test a positive, if you now have VDRL, which is non-treponema, and then you go and do the VDRL or the RPI, it is negative. What it means is that this is a past infection. Okay. If it's negative for treponema and non-treponema, it means that there's no syphilis. It excludes syphilis infection. If it's negative for treponema, okay, negative for treponema and positive for non-treponema, what it means that this is a biological false positive. So with all these things and based on what you have done already, I'm sure you'll be able to do your syphilis serological test more confidently and then more scientifically. Are you tired? Can we move on? Or we call it a day? Can we move on? Are you tired? Are you sleeping?
No, Grandpa.
So you can go on, eh?
No, please.
Yes, please.
No, I see some no. I hear some no. I hear some yes. Okay. All right. So I don't want to overload you. I want to be able to understand all that. The next stage is also very important, determination of titers. At this time, I'm sure a lot of you are sleeping already or tired. So you postpone to next session, which is Thursday, God willing. And then Saturday, God willing, we are going to meet. Because I want us to finish the module 2 this week. And then once we're able to finish this week with the module 2, we will break for you to, because the module 3 will be the seminology. And you have to do exams on the module 1 and module 2. So I plan that by God's grace, you should be able to finish the module 2 this week. And that will take us from Thursday and Saturday. We should be able to finish with the module 2. Then the following week, this is a suggestion. I'll give you a break for that week, and then you do your revision, and then you write the exams on the Saturday. The exam is still going to be online. So either Friday or Saturday, then you write the exams online. And then the following Monday, we begin the seminology. Are you okay with that arrangement?
Yes, I'm
Okay.
okay.
I think that's fine.
Okay. So the arrangement is that by God's grace, we should be able to finish with the module 2, that's the Andrology, Andrology 1, Andrology 2 will all be completed by the end of this week, which is by Saturday. So we have 2 sessions, Thursday and Saturday. Take note and make time for them. Thursday and Saturday, we are winding up the Andrology session 1 and session 2, which brings us to the end of the second module. Then the following week, you will have a break. And that break is to prepare you to do your revision for the exams. The exams will be on Friday or Saturday, whichever. But normally you open it for a whole day, so that any time of the day that you want to, if it's, let's say, Friday night, noon to Saturday night, midnight, that is 24 hours within that period. Anytime that you are free, you can have the test. All right. Please, the test is scheduled in a way that your number 1 can be somebody's number 10. So don't think that you want somebody to finish and then you can get, you mess up. Again, even the same question, if you attempt it and you are attempting it again, the answers can shuffle. So that if you have A, B, C, D, the answers for A, B, C, D, in the next round, the same question, the answers can now be reshuffled. So just take note of all those things. Otherwise, you get yourself disappointed. And once you're able to go through the slides and you are also able to follow the presentations, I'm sure nobody should fail. But in the unlikely event that you don't make the mark, you still have a receipt. You don't want a situation, and also take note, before the exams, you roll out our roll call for the attendance. If you have not attended about more than 70% of the lectures, you will not be allowed to write the exams. Take this from me. If you, and right from the time of the program, I think we are told the conditions that you should be able to partake in about 70% of the lectures. All right. And the records will be there. So you put up the records, and I'll instruct that if there's anybody who has not attended, not taking part in the exams, sorry, in the lectures for up to about 70%, you will not be given access to write the exams. You will not be given access. It means that you can listen, but you will not get certificate. Okay, so these are the things that you must take note. All right. If there's any question, please ask.
Some of us don't have the lecture notes.
Lecture notes, there'll be
the particular email they said you did not receive them.
The coordinator, the coordinator has taken note, and then I'm sure you all the uploaded.
Mommy, you know that today I cleaned the house.
Remember, please, it always normally takes time for it to be uploaded. If they can work on it for us.
Okay, it will be expedited, please. Somebody's daughter cleaned the house today, so that's good. Okay, so if there are any questions you want to ask, please do.
Yes, please. My question is briefly on the neurosyphilis. I understand the question and the response that came that VDRL is recommended for the neurosyphilis. I'm just thinking aloud that just like in the serum, where even if a person has been treated, then is continue to show positive. By just on top of my mind, if you use the same approach for the CSF for the troponemal test, it is also going to stay positive, as in it doesn't also clear from the CSF.
Right. Okay, that's good. So remember I said that with the CSF, we don't recommend the TP. We recommend the non-treponema. And then with the non-treponema, it's either VDR or RPR. And we said that the RPR is also not recommended for CSF for the reason that that's going to be macroscopic. Once it's macroscopic, it means that tiny distance or weak reactions will not be picked up. Okay, so the recommended standard standard method for detecting or diagnosing neurosyphilis is VDRL. You can read about it anywhere. You don't recommend any of the treponema tests. We recommend the VDRL. Now, we said that even though VDRL is not non-treponema, non-specific, however, as far as CSF is concerned, as soon as it's positive, take it as treponema, because all the things that will have given the interferences and the false positive, none of them will be present in the CSF. So if CSF VDRL is positive, it is conclusive. You don't need any confirmation. That's what I said.
Okay, thank you.
Okay, you are welcome. But I'll not say that because of this, go and buy VDRL kit and then put down in your lab. It will be a waste of money, because the question is, it's very rare. It's very rare to have neurosyphilis. So for about 5 years or even 10, you may not even get some in your lab. Okay. So if you go and buy VDRL and then put it in your lab, awaiting that you may get some neurosyphilis, the region will just aspire. So this is just to open up your mind that in case anytime you may be confronted with neurosyphilis, you should be able to tell the clinician that for this case, you need VDRL. The VDRL reagents are not available. So the best, if you still want to confirm, the best you can do is now take steps to now look out for VDRL test kit. You may have to probably ask somebody to, and that's also going to be difficult because the suppliers, they wouldn't go and buy one pack for you alone. And then they know that if they buy one pack, the cost may be expensive. So they want to buy, let's say, in large quantities. When they buy large quantities and they come and give you one box, who will buy the rest of the boxes? So most of the time, if for research purposes, then the person can go and buy it from the manufacturers for the research. But for routine laboratory use, I still may not be. I will recommend you that go and buy VDRL and put in your lab. What I would strongly recommend is the RPR, because almost everybody is using the TP test strip. The TP test strip basically are all treponema based. And once they are treponema based, they will continue to give us positives, even if the patient has been treated already. So for you to be able to confirm whether it is past infection or this thing, then if the TP is positive, you do the reverse algorithm. And then now try the test, do a reflex, and do the RPR test. If the RPR test gives you a negative report, then it means that your positive case is a past infection. Okay, and then you can write it TP positive, RPR negative. They make a comment. This is a probable case of past infection. Then the clinician will also know that the lab is doing very well. All right. Now, even though we are closing, but before we finish, before we come to, I just want us to take a quick look at the last slide that I've added, because I know that one of you asked me or told us that the traditional medicine people, anytime they are talking about syphilis, they say that it can make your penis shrink or get weak.
Yeah, I was the one who.
So now let's take a look at that aspect, because the technical ones are the tighter determination. Okay, so we deal with that one coming. So let's quickly take through the. So I have this few things for you: syphilis and male sexual functionality. Right. So all of us, we are aware that syphilis can damage blood vessels. Is it true or false?
True.
So do you agree that syphilis damage blood vessels and nerves? Do you agree?
Yes, please.
You agree? If for nothing at all, the penile ulcers should be able to damage some blood vessels and nerves. And do you also agree that the sorry? Do you also agree that the blood vessels and nerves play a role in erection? Do you agree to that? Based on the mechanism of erection that we learned. Do you agree to that?
Yes, please.
Yes. So if syphilis can damage blood vessels and nerves, then that one scientifically it is true that syphilis can cause erectile dysfunction. Do you agree to that?
Yes, please.
Yes. But look here. If you have syphilis, and for that matter, it causes erectile dysfunction, then over time, like the penis will not be erecting, but so you have a sense that probably because the penis is not erecting, you will see the full strength of the penis once there's erection. Okay, and once you have that kind of erectile dysfunction and the penis is not erecting for you to know that it is big, you always get the sense that probably your penis is becoming small. So there's no science behind the analogy that if you have syphilis, it will make your penis. There's no science behind it. So what can be established is that syphilis can cause erectile dysfunction. That one is true because syphilis can damage your blood vessels. They can also damage the nerves. And you all know that the mechanisms for erection is largely influenced or controlled by blood vessels and then the nerves. So once these are damaged, to some extent, erectile function will be compromised. Once the penis is not erecting, you get a sense. You know, we talked about the penile dysmorphism, all right, and then the penile dysmorphism disorder syndrome, where people, when they have in your mind that, oh, I'm saying, no matter what we tell them, it's like it goes with them. Okay, so they get that thing into your mind, and then they make you think that, oh, a friend is saying my penis has become small because of the syphilis, but there's no science behind it. The only science behind it is that syphilis can cause erection to be compromised, and once you don't get erection, automatically, not that the erection, the penis will become small, but because you are not seeing the full strength, the full size of your penis, then you get the impression that probably the penis is becoming small, but technically it doesn't. So while not actually shrinkage, the inability to achieve full erection can give the appearance of a smaller penis. Are you following me? So you get a, but what it is causing is rather inability to erect, and that inability to erect will eat into the person's mind that my penis is getting small. But in actual size, the syphilis has nothing to do with the shrinkage of your penis. All right. Syphilis can lead to complications like gummas, soft tumor like growths, and the nervous system problems. So, and the gummas are associated with fourth stage, the tertiary stage syphilis. You get some big wounds all across, and then causing a whole lot of. So it means that at that stage, they can also cause a lot of problems for the erectile function. Okay, so it is the functioning of the penis, and for that matter, the erection, which will be affected. That one, there is no two ways about it. It will affect it. But it was not going to give you, it is not going to be a direct cause for shrinkage. Only thing is that it is going to continually give you that kind of continual inability to erect. And once it is not erecting, you get the sense that probably the thing is getting small, but not actually this. So syphilis can also cause nervous system issues, including headaches, stroke, and all those things. And all those things can impact on penile function, leading to potential erectile dysfunction. So what scientifically can be proven is a link between syphilis and erectile function, not the shrinkage. We've learned that the only thing which is likely to cause erectile or penile shrinkage, who can tell me? What is the only disease that can directly cause penile shrinkage? You've forgotten. Who can tell me? Eh? No, as for Barry Penny, it's a condition on its own. Why I'm saying that we are talking about a condition like sorry, a disease condition that can give you shrinkage. The peronis. You remember you said that when you have a peronis, what happens is that there is a tear or a fracture, and that fracture will heal, and the healing can give you that kind of fibrotic. You see, like the fibrous nature. So that one will pull the tissue, the erectile tissue will pull it. Okay, once it pulls it, what is happening? It is causing the curvature of the penis, and also at the same time also reducing the penile length. So that's where, so whatever is likely to happen, there must be a science behind it. But for the syphilis, I want to tell you that it can only cause erectile dysfunction because a lot of blood vessels and nervous system will be affected. And once you know that the erection is controlled by blood vessels and nerves, once they are affected, then erectile function will also be compromised. And once your penis is not erecting, you get the feeling, and that is the penile dysmorphism disorder syndrome, where I told him, so people are just using the saying all those things on air, but there's no science behind it. Are you okay?
Yes, sir.
Okay. So, yes. All right. So tomorrow you'll be, God willing, Thursday you'll be doing the
titus,
the serial dilutions. All right. On that note, you call it a day. See you on Thursday, God willing. And take note, next week you will break for your exams and you have to study for it. Good night.
Good night.
Good night. And if you have time, I report correctly. It was you felt you can more very much anything that to deal with it and